I'm so pleased to be here today and be leading this discussion about how to fill the gaps in mental health care needs for the global community of people living with childhood onset heart disease. I am joined by some very amazing panelists, really my personal heroes, and I will be introducing them as I invite them to speak. But I want to start out to explain the rationale about why we are focusing on mental health starting out, because you might notice if you look at our agenda, this is actually the only specific health problem, if you will, that this agenda focuses on. And there's a very clear reason for that. So many of you may be aware that we had a summit about a year ago, a little over, at the World Congress of Pediatric Cardiology. We brought together over 60 patient and family leaders from around the world, and we did a lot of exercise to identify common gaps and challenges. And what was blaringly clear in every country, it didn't matter whether it was a rich country or poor country, the issue of unmet needs in mental health care and the gap between what patients need and what they're getting rose to the surface as the #1 global issue that we all shared. I will note as well that we know that this is the most common morbidity for congenital heart patients around the world, and that has a major burden on rheumatic heart disease and other childhood onset disease, and that we know that this problem impacts not just people's mental health and social health, but their physical health. And I'll also state that there was a recent statement put out in 2022 by the American Heart Association, American College of Cardiology, which stated very clearly that we have 20 years of research on this problem, and yet there really has been minimal progress in filling this gap for patients and families. And this statement explicitly said that we need more advocacy and action especially led by patient family organizations in collaboration with clinicians to fill these gaps. So my pleasure today is to introduce our 3 panelists, each of whom has created a specific strategy and project that has made a major impact on filling that gap for mental health needs, whether it's in their community or nationally and globally. So I'd like to introduce first Flavia Camalembo. Flavia is a person living with rheumatic heart disease, and she is also a critical care nurse at the Uganda Heart Institute. And Flavia, I'm not seeing you now. Can you turn on your video? If you could talk, that's great. If you could talk, specifically, let's start out with if you could talk and describe the patient support group that you were able to begin and is existing at your heart center, and how you did that, and what you're seeing is the impact on the patient community in Uganda.
Thank you, Amy, and thank you, everyone. Good evening to you. It is 8:46 in Uganda p.m. I'm happy to be part of this meeting, and I'm already impacted by the different things people are doing. The Lagos experience is so amazing. I'm happy to share with you about this mental health need that we are tackling. My name is Flavia. I am a nurse. I am a patient living with rheumatic heart disease. And that combines one person with 2 things that match each other. So, and I'm happy to be part of the Global Arch board members, which has taught me a lot of things. So I'm happy to talk about the mental health needs that we have overcome as a country. So in Uganda, we have what we call patient support group, and this is under the hospital. It is under rheumatic heart disease support group under the Uganda Heart Institute that we formed since 2016. We've been incorporating different members, and we do different activities which have managed to tackle people's mental health. So if I can just share with you my experience, if you're told to walk on a slippery road, the person who has walked on that slippery road will help you walk it better because they know the place that is most slippery, they know where your feet can stand, they know you can move very well. So when I look at the patient support group that we have, it is like a guide, it is like a support that we have put for people to walk in a slippery road. If they told you one morning walk and the road is that one and you see it's slippery, the one thing you'll be scared of would be like, how am I going to walk on this slippery road? But when you find someone across and the person tells you, I've walked, I moved, it was hard, but I moved and I went through that road, it encourages you, it gives you hope that if these people are walking on this road and they've reached this far, even me, when I walk on this road, I'm going to reach where they are going. So the patient support group we have in Uganda, it is one of the group that does those things. When you get a patient, first of all, they are mentally down. Why me? Why at this time? Why did it have to be on me? Couldn't other people also face it? So when we get these patients, we enroll them in the patient support group. We talk to them, we tell them the journey about the disease. We give them hope. We tell them, yeah, it is this, but there is hope. It is not all over. We talk to them and tell them, yeah, you're going to go through this at the moment this is happening. So we help them walk on the slippery road before them that they're afraid of walking. So with the patient support group, that is one thing that has encouraged me. Someone would say, you are a nurse, you have that disease, you know everything about it, you can overcome it. Me too, as a nurse, I needed someone talk to me. I needed someone tell me that, yeah, you can walk through this. So I'm imagining someone who is not even a nurse, who even doesn't know anything about the disease, how they would be feel if me who knew about it was overwhelmed, was shocked, and I needed someone to help me move in this road. So with the patient support group, it has helped us bring in different patients, support them to move in the slippery road, give them hope, and lead them to where we want them to go. We have shared experiences with some of them. Some of the problems that disturb patients sometimes are not even medical. They are just things you need to sit down and talk with someone to empower them and support them mentally to be able to overcome. Yes, that's what I could share. Emmy, I don't know if there's anything else
Thank
you want
you.
me to talk about.
No, that's wonderful that you've been able to achieve that. And I want to note that what's so exceptional is the way you've been able to integrate it in the clinical program. It's really available for the patients that are being seen at that Uganda Heart Institute. I want to turn next to Dr. Nadine Kasparian, who is a researcher and clinical psychologist and clinician at the Cincinnati Children's Hospital, but she has also the founder of the Heart and Mind Wellbeing Center for adult congenital heart disease patients in Cincinnati. And Dr. Kasparian, I know that you've really also achieved something quite exceptional in a clinical setting, which is you've managed to get this center started, which is really exceptional in providing psychological services. So can you talk to me a little bit about how you were able to get there and what the impact has been?
Oh, well, thank you, Amy, and thank you so much for elevating mental health in this summit. It's incredibly important. And as everyone has said so far, I've learned an enormous amount already. Our Heart and Mind Wellbeing Center at Cincinnati Children's Hospital opened early last year. And we are dedicated to transforming mental health outcomes for people with all forms of pediatric or congenital heart disease. My team is a multidisciplinary team of providers who specialize in providing care for people affected by heart disease. So it includes a team of medical and clinical psychologists, a dedicated neuropsychologist, a child life specialist, social worker, and clinic coordinator. And we really built this program from the ground up very much highlighting what Dr. Matos very eloquently shared earlier on, which is that we recognize from the very beginning that there is no one size fits all, and that care really needs to be tailored to each individual and their needs, preferences, and beliefs and values. So at the heart of our program, we take a lifespan approach to mental health care. We often say that our youngest patient hasn't been born yet when we care for parents who have received a prenatal diagnosis of congenital heart disease for their baby. And our most senior patient at the moment is 74 years young. So we really do provide a lifespan approach that allows us to work with infants, children, adolescents, and adults across all ages and stages and across all areas and parts of their medical journey, whether that's while they're inpatient in the hospital with us or outpatient at home, in school, at work. We provide care for the whole family. So not only the person who has heart disease, but their parents and caregivers, grandparents, brothers, sisters, siblings, partners and spouses, and also bereaved families. And this may seem like the obvious thing to do, providing that holistic family-based care, but it is actually very rare to see that kind of care in congenital heart services. So we really did build that into the foundation of our program. Our care is embedded in cardiac care, and this collaborative approach is really designed to normalize and, importantly, destigmatize access to mental health care. So heart care and mental health care in our hospital go hand in hand. We work together to really provide that collaborative approach so that mental health care is part of the routine process of our care, but also it's embedded into the culture of our care. And we're really so proud of being able to have a footprint across every clinic in our Heart Institute. We receive referrals from every part of our cardiac care program, and that really is a symbol of the collaboration that we have with all partners across the Heart Institute. The other really important thing about our program is that we integrate research to be able to advance science as we care for our patients and families. So many of our clinical trials are embedded into our Heart and Mind Wellbeing Centre, and research and clinical care go hand in hand so that as we learn, we are rapidly translating science and the evidence into clinical practice so that we're always offering the most cutting edge and the most advanced treatments and intervention strategies. And I know our next panelist will talk about this, but also included in our program is the need to really work towards health policies and really working at that health policy level to make change, something that happens not only at a few bright spots across the globe, but also is something that we can share and we can learn from one another, and we can build together not only locally but nationally and internationally. The only other thing I'll mention, and I saw this as one of the really important goals for your new initiative, is that in our program, we take a really aggressive approach to addressing barriers to mental health care. So for a long time, as you mentioned, Amy, we've known about the things that make it hard for people to be able to access the mental health care that they may want and need. And so we really take a very proactive approach to understand what are some of the barriers or challenges that may make it hard for our patients and their families to be able to access the care we provide, and we work towards solutions to address those prior to really even meeting the families that we care for.
Great. Thank you so much. And it's really exceptional that you've been able to achieve so much investment and attention at your program. The next person I want to invite to comment is Dr. Liza Morton, who is a counseling psychologist and has a background in research and is also an author of a book called Hearts and Minds. She's a person living with congenital heart disease, and she has advocated for many years to make positive changes to fill the mental health needs of patients living with this and actually other chronic conditions. Um, so Liza, we'd love to hear more about your efforts, both in terms of learning more about this through your book and providing, and also through your health policy work.
Thank you, Amy. Hi, everybody. It's an honour to be here. I would quite like to move to Nadine's service as a patient now, but I'm over here in Scotland. So yeah, where to start? I've been very much involved in advocacy work and CHD and as a psychologist and in research as well. So the two things I wanted to mention today in the kind of context of successes are, first of all, the healthcare standards that we have in Scotland that were published at the end of last year. So that was a piece of work that began over 10 years ago when I submitted a petition to the Parliament here in Scotland asking for healthcare standards for the growing population of those of us with congenital heart conditions. So we didn't have any healthcare standards at that point. And I had several life-threatening incidents with my own care and had struggled to access healthcare basically since reaching adulthood. So, but that did culminate in some quite scary incidents that I had. So anyway, to cut a long story short, it was a very protracted, long journey, took over 10 years. And I think Amy is going to post a link to the standards, but also to two blogs that if you're interested in how they became. There's one that I wrote on the importance of patient involvement in the development of standards like this. And then there's another one that I wrote that was about the importance of having a full standard on mental health. So this was something that I was very adamant about from the start and really stuck to. And it's actually the first time in Scotland that healthcare standards have included one specifically about mental health. And the standard is mental health and emotional wellbeing across the lifespan. And hopefully that will underpin the kind of funding for the service, the national service, but also local provision of mental health service provision. There's been a lot of work in Scotland around trauma-informed practice, and I have noticed that health conditions have been missing from that agenda as well. So I was able to pull in some of that legislation and get that embedded in the standards as well. So I'll let you look into that with those links if that's of interest. The other thing that I wanted to mention in terms of success is our book. So you may be familiar with this book. So Tracy Levesque and myself are both patients with lived experience. We met online and we actually wrote this whole book before meeting in person. She lives in Connecticut in the USA. And we basically are both mental health professionals. She's a licensed clinical social worker, and we had kind of met through, I've done a lot of work with the Somerville Heart Foundation, and Tracy's done a lot of work with the peer mentorship program with the Adult Congenital Heart Association in America. So we discussed the fact there is absolutely no resources, there was no books. If you look up childhood cancer or other conditions, there was a plethora of resources and we couldn't find anything. So we decided to write the book we'd been looking for. Thankfully, we've had a really warm and positive response to our book, which has been lovely. And it's also been adapted by Meredith Kalbiker at the Mount Sinai Hospital in New York under Dr. Zaedi's adult congenital heart service there. So she adapted it into a self-help group, which was really successful. And it was then picked up by Pauline Ayton more recently at the Bristol Heart Institute and has now been rolled out across Wales and London, and was presented this year as an abstract at the European ACHD conference in terms of results from that. So they've found it useful to kind of use the chapters as the structure for a group, and they've done it in different ways. Some of them as kind of more a book club, some of them more as a kind of guided self-help. So it's been great to see these developments coming from the book. And I'm also very interested in terms of my own work, looking at how we can mitigate mental health problems. So, you know, as others have said, we've now established mental health as something that is a real comorbidity with the ACHD population. But I feel personally, having walked that path, there are many things across the healthcare journey that could be done and improved to make healthcare itself more psychologically informed. So I do have another book coming out next year called Psychologically Informed Healthcare, and that is my main kind of interest now is, how do we kind of better marry what we know in psychology with what we know in medicine to prevent and mitigate the risk factors for mental health, rather than waiting until the horse is bolted and kind of going into having to fix and treat people when the kind of hurts have already been done. So I'll stop there.
Thank you so much for all your work and for all the information. I'm going to follow up with some very specific questions. So each of you have been able to achieve a lot of impact. But as we noted at the beginning, this continues to be really hard to do. So I think, there's a big gap still. So I want to ask each of you about an aspect that stands out that I know is a barrier for moving these kinds of projects forward. So first, I just want to ask you, Nadine, in my experience, certainly in the US, working with the adult congenital heart standards, the biggest barrier we had when we were creating those standards, or one of the biggest barriers, was getting investment, really just getting hospital systems understanding this problem and investment, because we know this is a money issue. You have to invest in that staff. And also, when you talk about research, we know that even though this is an important area, and Liza was talking about this, we need just comparative effectiveness research, not just describing the problem. You're doing it. So how did you get, very specifically and succinctly, how did you get your administration on board, and how did you get the money?
Great question. First and foremost is prioritization. And I'm very lucky to work at an institution that places mental and physical health at an equal space on the table. So we really do prioritize mental health equally with physical health. Now, one of the keys to our success has been integration. Integration is important from a patient and family perspective because of the reasons we've already talked about in terms of normalizing access to mental health care and destigmatizing that care. But it also helps in terms of resources. We're able to share resources, we're able to share challenges, and we're able to be really transparent about what mental health care looks like and the difference that it makes. And I think once you're able to do that, it really often speaks for itself. But I also wanted to touch as a third point in answering your question, the other key component, which was talked about earlier at the beginning of this summit, and that is advocacy. So you really do need advocacy at every level in order to be able to have a program such as this succeed. Patients and family members are absolutely vital and were a really pivotal aspect of us being able to successfully stand up our program. But you need champions at every step of the way. Your cardiac surgeons, your cardiologists, your hospital executive, your nurses by the bedside. You really do need champions in every space. And that can only come from having a shared vision and building this together. And that is what we were able to do.
And it's very exceptional. Thank you. Liza, my follow-up for you is, again, I want to focus, you've done so much on your advocacy work, because one of the clear inputs we got in Washington, D.C., which was very interesting, is that even in countries that have healthcare standards, for well-advanced healthcare standards and full health coverage, such as UK and a lot of Europe, the feedback we got from the groups is that this still isn't taken seriously, and it still isn't frankly just funded, it's very difficult to actually access care. I'd love to hear your comments on how you were able to get specifically mental health referenced, and what is the impact so far? Is this actually making change? And how do you think sometimes with these things you have to keep following up. So what do you see as the next steps in terms of making sure that this aspirational standard actually reaches the patients in Scotland?
Yeah, that's a good question. And obviously there's often a gap between the standards and implementation of the standards. I guess that over the last 10 years since I submitted that petition, which asked for standards, but also asked specifically for mental health support as well. And I'm not saying it's exclusively because of that work. There've been many other factors at play, but we do now have, which we didn't have before, a dedicated psychologist at the National Service for the Congenital Heart Service that wasn't there before, who also has trainees. So that does exist, and it didn't previously. There are still huge gaps. It's nowhere near good enough. There are still gaps in terms of local care provision. And I guess the only way that I have managed to be successful is by just going on and on and on about it. I cannot tell you the number of meetings that I have been in over the last 10 years. If you look at my blog, where the one about patient involvement, you will see how many different committees I had to go through, how many different times we started again. There were blocks, there were huge medical politics. It was an incredibly steep learning curve for me. I thought you took the problem to the government and they would fix it. No, I took the problem to the government and found out we weren't even on the health agenda. It was coronary heart disease. So I was stunned to just even learn how these things work. So it's been a very steep learning curve. And the only thing that kept me going was my own lived experience and actually anger at the injustice. And that anger, I had to do something with that. I have never received any psychological support I have privately, but through care. I have never once been asked at any medical intervention or post-surgery if I need any psychological support, including being told, life-threatening situations, or, I've had countless surgeries. There have been situations where I've had a young child and I've not known whether or not I would survive a surgery. Never once have I been offered psychological support. And the episodes that actually were life-threatening for me made me so angry, because I felt like I'd had such a difficult childhood and I had overcome so much, and I was so let down in adulthood, and I nearly lost my life after having a child. And I just thought, why did you even bother to save me as a child? To have that childhood, to not survive into adulthood. And I guess I just keep going back to that and thinking about, it's hard growing up in a heart ward and you see other children and you witness suffering from such a young age. And for me, I would sit in meetings with, doctors, nurses, and then kind of administrative staff. And I would think, I'm the only person here that can speak for those children, because I'm the only person who has been through it. And I just kept returning to that. And that kind of orientated me and just gave me the strength to be able to speak up in meetings. And I just thought, I don't care if this is like the kind of manager of the whole NHS in Scotland, or I don't care if you're, kind of some political kind of key figure, because this is important and I know it matters. So it's not right what's going on here. It's not right for children to suffer in this way, and it's not right for them to it's hard enough living with a heart condition from childhood to then not get the care and support that you need. So yeah, I just kept banging the drum, and
I think you just did a really good case for Global Arch's mission, right? Global Arch feels very strongly that the patient and family organizations at the end of the day, and I know Dr. Kasparian and Nadine talked about this as well, that at the end of the day, it's those voices, both individuals and the organizations. I know that many of our organizations that are here are really trying to get that. But the other message I hear from you is persistence, right? advocacy, one of the frustrations of
Oh,
advocacy,
yeah.
you have to go
Yeah.
back. You can have the best policy, but you have to make sure
Mhm.
they do it. So that's
Mhm.
wonderful. And I know also you mentioned the Somerville Foundation, which you're working with.
Yes, yes,
You know,
definitely. And I had to mention Michael Cumper, who sadly we lost recently, but he was a massive support to me in developing the standards. You know, a really
right.
amazing mentor and mentored me through all of that.
Great. Thank you so much. And Flavia, my specific question for you, um, it's interesting. We know that peer support, we have research, can make a huge difference. But at least in the US, it's usually in a silo. It's not usually something that clinicians actively connect people with or embed. We heard that in Nadine's center. They actually embed peer support in it. And Dr. Zaidi was given as an example. But that's a big challenge, is that this is a hugely underused, free, accessible resource. So, Flavia, it sounds like your program is really integrated. And I'm very curious, like, how did you get that? How did you get the clinicians as well as the patients sort of taking for granted that this was an important to have the peer support and then refer their patients through it consistently?
Okay. Thank you, Amy.
We
Uh,
can't see you right now, so if you can turn on your video, that'd be great.
okay, sorry.
That's
All
great.
right, thank you so much. And so in our work area at the Heart Institute, we have a dedicated nurse. Every morning, the dedicated nurse goes through all the patients, identify those ones with rheumatic heart disease. So we also have a registry where all these patients are captured. And in the morning, when these patients come, we go out and identify how many we have. So we record that today we have 15 rheumatic heart disease patients, we have 10. So after knowing that we have maybe 15, 10, because we record every day, and when these patients see the doctor, we work with the doctor that sees the patient and tell them before the patients go, they go through the registry room. So when the patients leave the doctor's office, their last point before they go to the pharmacy is to go through the registry room. And we have worked with other departments where patient flows, like the pharmacy, because sometimes the patient may leave the doctor's room and they know next is to go to the registry room, probably because they are tired, they want to go. So we talk with the pharmacy. So when the patient goes to the pharmacy department to pick their daily medications, they ask them, you need to go to the registry to discuss with a nurse that is there. So every morning there is always a nurse that is dedicated to the room to attend to rheumatic heart disease patients. So every time the patients come, they go through the queue, see the doctor. The last point is to go through the registry. So when they come through the registry, we meet them, discuss with them, identify their needs. And so this is done daily in our outpatients department. It is not something that we do for a week, but it's done daily as patients come. So when they leave the doctor's area, they come to the registry room. So in the registry room, we have a dedicated nurse that discusses with them, understand their needs, answers their questions, any counseling they need. So that's how we've been handling it at the moment. And then after discussing with the doctor at that point, then we recruit those ones that are able to join our support group, because the support group mostly works online, and we meet like quarterly or once in a while. So we ask those ones that are able to join the support group that would need to keep in contact with other patients. We ask them to join, recruit them, and then we go on with the counseling and the journey process of the disease. But that's how we usually get patients and incorporate them into the daily needs as they come for the outpatients department. Yeah.
That's really extraordinary. So it sounds like what you're saying is this is a routine part of the care. not just what meds they need, but this is integrated into everybody's care and a referral to people.
Yes, it is part of the care. Like every time they come to the hospital, we identify them and then they go through the room that has a dedicated nurse that is there to talk to them and counsel them. So it is part of the care every day that we do as patients come.
Which, as Liza noted, many people in much richer countries don't get. Unfortunately, we're at time. I wish we could talk more about this central issue about how do we help all of us living with congenital heart disease, myself included, thrive and thrive with our mental health as well as our physical health. If people have questions, please type them in the chat. Unfortunately, we're not going to be able to take questions live, but we'd love to get back to you. And I'm going to turn it back over to Kate, I believe.
Yes.
We're going to have our breakout groups now. So thank you so much.